Thank you for having me. It's nice to see some familiar faces in the audience. I'm a junior faculty member at Stanford, and I take care of people in what we call the Center for Inherited Cardiovascular Disease, and one of the conditions that I take care of for the most is people with familial hypercholesterolemia. And I always like to give my audiences a quiz just to keep them on their toes. And so you don't have to write these down, but if you want to keep an eye or have an answer in mind, we'll go over these at the end. So I hope that by the end you'll know more than you did at the beginning. So one is, how common is FH in the general population? Okay, we know that one already. She stole my thunder. FH patients are at what fold increased risk of a heart attack or myocardial infarction? What is cascade screening? What is the goal LDL cholesterol for an FH patient? And mutations in 3 genes cause FH. What are they? And I do have one conflict of interest, and that is I'm the chief medical officer for a patient-led charitable organization for people with FH. And afterwards, I have some material that I can pass out to you. I always like to start the talk with a case presentation because that kind of crystallizes the idea for why we think this is important. This was one of the first patients that I ever took care of that had FH. And this was a 38-year-old woman. Some of you probably have children that are 38 or older. And she had a normal childhood, and when she was young, she was told that she had elevated cholesterol, but that she was too young for treatment. She got married in 2004, and then she had her first child in 2009, and then about a year later, she started having chest pain when taking care of her son. And well, obviously, if you're running around after a 2-year-old, sometimes that can give you anxiety, but it doesn't typically give a 38-year-old woman chest pain. So then she went to see her doctor, who checked her cholesterol and found it to be so elevated that he was scared. He referred her to a cardiologist who did a stress test, and some of you have probably had a stress test where you run on a treadmill, and hers was markedly abnormal, and she was scheduled for angiogram. And unfortunately, on the morning of the angiogram, while sleeping at home with her in bed, she began to groan, act in distress. Her husband got concerned. She became unresponsive. He started CPR, called 911. They found her to be having a cardiac arrest. She was resuscitated, fortunately, and found to be having a very large myocardial infarction or heart attack. She was transferred to Stanford. They whisked her away to the cath lab, and I'll show you some pictures in a second, but she had severe 3-vessel coronary artery disease, which is the most severe you can have. They had to put in a ventricular assist device, or artificial heart, and some people would call that, and place some stents in her arteries, and ultimately really saved her. And movies are also can kind of grab people, and this is the movie of her cardiac catheterization prior to her over here is prior to her stents, and you can see that this is the catheter. These are all X-ray pictures, and we inject dye into the arteries of the heart. And what you normally would see in a 38-year-old woman is that these would be wide open, just like pipes, nice and smooth and big and large. And what you can see in hers is that they're very stenosed, and the dye is having a hard time getting through there. And so this is the pictures afterward. This is the artificial ventricular assist device. This is helping pump blood that her heart can't pump by itself. And they placed some stents here, and so the blood flow is improved. It's, of course, nowhere near normal. We can't cure her, but we did save her life. And so going back in the retrospectoscope, this is why her primary care physician was worried. Her total cholesterol was 327. Probably many of you know your cholesterol levels, but that's way higher than normal, probably about double what normal would be. Her LDL cholesterol was 265, which is also more than double what it should be. And then I'll show you some of the physical exam findings she had that are telltale signs of FH. So how common is FH, and how do we make that diagnosis? Well, this is a graph that shows how common it is amongst a slew of diseases that you probably heard of. And this is per 100,000 people, and FH happens in 1 out of every 500 patients worldwide. That means it affects every race, ethnic group that you can imagine, and it's actually more common in some. This is way more common than diseases like cystic fibrosis or Marfan syndrome, and it's even more common than hypertrophic cardiomyopathy, probably. More common than multiple sclerosis. All of these diseases you've heard about, or many of them you have, but I would guess how many of you had heard of FH before this talk? None, maybe one. We know why you've heard it. And so there's 620,000 patients in the United States with FH. We estimate that, but less than 10% know that they have this diagnosis, and probably it's more like 2% know they have this diagnosis. The average LDL is 220, again, more than double what we'd like to see. And they have here's one of your quiz question answers. You have a 20-fold increased risk of having a heart attack if you have FH. If you're unlucky or lucky enough to be born in some of these populations, it's even more common to have FH. If you're from South Africa, you're much more likely to have FH. If you're if you're a French Canadian, you're much more likely to have FH. It's just because at some point in the distant past, there's a founder effect. Somebody in this small population had FH and passed it on to a lot more of the people, their descendants. Now, FH comes in 2 flavors. And the reason for that is because if you inherit one bad copy of a gene from your parents, you have a FH, a severe form of FH. But if you inherit a bad copy from mom and a bad copy from dad, you have a very, very terrible, severely disease called homozygous FH. And I'll talk about that briefly here. The majority of the talk focuses on heterozygous FH because that's much more common. But homozygous FH is very rare. It affects only 1 in a million people. That's 1 in 500 times 1 in 500 times 1 in 4 equals 1 in a million. The LDL cholesterol is usually above 500 milligrams per deciliter. You have severe vascular disease at an early age. So most kids with homozygous FH will require apheresis therapy, which means it's sort of analogous to dialysis, but you basically have your plasma scrubbed of cholesterol every week or 2. And many will die by their 20s or 30s from severe vascular disease. They also have other consequences. So this is a really terrible disease, and one which we'll talk about a little bit later in the talk. But again, this is only 1 in a million, but the more common form of FH, where you inherit a bad copy of the gene from one of your parents, happens in 1 in 500. So how do we diagnose it? Well, there is an app for that. You can go on the web and find an app for the diagnosing FH. But physicians should suspect FH if the LDL cholesterol is greater than 190. And there are, as we age, everybody's cholesterol gets higher in general. But if it's above a 190, we should start to be suspicious. That's not diagnostic in and of itself, but that's where we should be suspicious. There should also, in FH, it's much more likely that you'll have a family history. A brother or father, your mother, your grandparents died at an early age from coronary disease. And then there are some specific physical exam findings for FH that we often see. And they're called xanthomas. These are cholesterol deposits, actually, that deposit in the Achilles tendons, on the hands, around the eyes. These are called xanthelasmas. And then this right here is called arcus senilis. It's just a little discoloration around the iris. Now that's less specific for FH, and many people, as we age, especially those that spend a long time outside, we get this arcus senilis. But again, if you find it at an early age, you got to suspect FH.
What was that last one? Sort of a lightning?
It's a lightening around the edge of the iris. Once we suspect that somebody has FH, we can plug these numbers into these apps that can calculate your score for FH. And they're all basically a combination of what your cholesterol is, whether you have these physical exam findings, and what your family history is. And they will spit out a number that says you're likely to have FH, or you're unlikely, or you're definitely likely to have FH. Now, I'm just going to show you this slide to give you a feel for what happens to all of us naturally as we age and what implication that has for the diagnosis of FH. So normally when we're born, our LDL cholesterol is less than 100. Little babies, when their brains are developing at their most rapid, their LDL cholesterol is less than 100. As we age, all of us accumulate cholesterol. You accumulate cholesterol in the liver, and so as we age, everybody's cholesterol goes up. But in the general population, if you have an LDL, again, around, this is the LDLs, or in parentheses, above 190 or 200, you should strongly suspect FH. But if you want to be as stringent as possible, you would really have to have a little bit higher LDL just by itself to be absolutely certain that that person has FH. So again, FH is not just your cholesterol level, it's also your family history and your your cholesterol, your family history, and your physical exam findings.
Excuse me, is that if you're not taking medicines?
Yeah, if you're not taking medicines, you have to work in a correction factor if you are taking medicine, certainly. And so this is a very important slide, I think, that illustrates the quandary for FH, because the normal population, here's non-FH patients, there's a distribution of here's your LDL cholesterol values, and here's the probability of having those LDL cholesterol values. So in the United States, the average LDL for an adult is something like 130 or 140, something like that. But there are normal people that have an LDL that's lower than 100, and there are normal people that do not have FH that have a higher LDL than that. These are people that have other reasons for having high cholesterol, or they eat a lot of McDonald's, or they're very sedentary, or whatever. Now in FH, your average LDL cholesterol is much, much higher, but there are FH patients that have LDLs that are overlapping with normal. So the key is to try to figure out which of these people has FH and which just has a garden variety high cholesterol. And the reason that that's so important, I'm going to tell you in the next couple slides. So how do these people present? Well, again, I've told you that they present, FH patients often present with coronary disease. And why does that happen at an early age? And it turns out that it's the lifelong burden of LDL cholesterol that causes the problem. So again, what I was saying earlier is that most of us that don't have FH, you're born, your LDL is less than 100, and then as you age, it starts to slowly accumulate. And so normally, if you calculated, if you looked at somebody's age, how old they are in years, and the cumulative LDL that their blood vessels are exposed to, a normal person would be exposed over time to this amount of LDL cholesterol. And around kind of this area is when you start to experience heart disease, heart attacks, vascular events, strokes, etc. But if you're a FH patient, you're born with even at the time of your birth, your LDL cholesterol is much higher than a normal person's. And so your lifelong burden of LDL is much higher than a normal person's. And so you accumulate that level of cholesterol instead of by your 40s, 50s, or 60s, you accumulate the level of cholesterol necessary to precipitate events by your 30s, 40s, 50s. Does that make sense? Yeah. So here's another one of your quiz questions. Heterozygous FH, that's the more common form. There's a 20-fold increased risk of heart attack. And to spell this out in a little bit different way, if you're a man and you are unlucky enough to be born with FH, and you don't get treated, you don't get diagnosed, there's a 50% chance that you'll have a heart attack by age 50. And if you're a woman that is untreated with FH, you have a 30% chance of a heart attack by age 60. And so it's really a huge healthcare burden, as you can imagine. Now, what about the genetics? I've told you that this is a genetic condition, which means it's passed in families. And FH, it turns out, is what we call an autosomal dominant disease. That means, again, if you inherit one copy from one of your parents, one bad copy of the gene, then you're going to have a severe form. If you inherit two bad copies, you're going to even have a much more severe form. So it's autosomal dominant. It's 90% penetrant. And what that means is that if you have a bad copy of the gene, you're going to have high cholesterol. There are very few people out there that inherit a bad copy of the gene that manage to avoid high cholesterol. Again, it's 1 in 500. The homozygous form was 1 in 1 million. And there are really 3 genes that are known to cause, mutations in 3 genes that we know of now are known to cause FH. And all of these genes are involved in the cholesterol metabolism, mostly involved in scrubbing they're in the liver, or they act in the liver to scrub the cholesterol from the blood. And these mutations occur in these genes. The LDL receptor, well, that makes sense. This LDL receptor sits in your liver, and the cholesterol particles come by. It binds those cholesterol particles, it internalizes them into the liver, and the body metabolizes it. PCSK9 is a protein that actually binds to the LDL receptor, and it tells the body to downregulate it or get rid of it. So if you have very high levels of PCSK9 in your blood, you degrade the LDL receptor. if you degrade the LDL receptor, the body doesn't scrub the cholesterol, you have very high cholesterol levels. Or ApoB, which is the particle that sits on the cholesterol particle itself that binds the LDL receptor. So obviously, if you have a mutation in the protein that actually binds the LDL receptor, you can also develop a high cholesterol. And I'm going to show that here in the next slide in a little bit of a diagram to make it a little bit more clear. So here's the liver cell. This is the outside of the liver cell, as connoted by this kind of membrane. This is the inside of the liver cell, and this is the plasma. This is the blood and the plasma, and these are the cholesterol particles that are floating around in all of our blood. ApoB is this little protein that sits on the outside of these lipoproteins, and it binds to the LDL receptor, which is in green. And so obviously, if you have mutations here or here, that causes problems. And then PCSK9 is an enzyme that actually acts to degrade this LDL receptor. So this is the genetics of FH. There are just in the LDL receptor, we know that there are over 1,600 mutations that can lead to FH, and there are many other mutations in these other genes that can cause it. Does that make sense so far? Anybody have any questions?
1,600 of these.
1,600 mutations in this particular protein, and you only have to have one to lead to FH. So I've told you that FH is a genetic condition. I've told you that it's passed in families, and I've told you that we can figure out which genes are causing it, and that leads to the next idea. And the next idea is cascade screening. Now, raise your hand if you knew what cascade screening was before the start of this talk. Nobody. I mean, this is actually probably the most important concept for public health that we really need to get across. And cascade screening it basically means if you identify one individual in a family that has FH, you're obligated to look at the rest of the family for FH. You can't just wipe it under the table and say, I'm going to treat that person, I'm going to neglect everybody else. Because once you find that one person, you're guaranteed that 50% of their first-degree relatives, their parents, their sisters, their brothers, et cetera, are at risk of having FH. And so that's why cascade screening is a must. And in many countries, in Europe especially, cascade screening is a national priority. And I'm going to tell you about the experience in two countries, in particular in the UK and in the Netherlands. They've used cascade screening to great effect. They've identified individuals with FH. They've gone out and had public health efforts to identify other family members with FH. And in that way, they've saved countless lives because of those efforts. So basically, how do we do cascade screening, or how would we do cascade screening? Well, the first thing is that you identify that one patient that has FH, and then you find out what their cholesterol level is. And in many of these European countries, they also do a genetic test. We don't routinely do that in the United States. I'll talk about that in a little while. And if they have a gene mutation identified, then you can screen the relatives for that genetic mutation. If they don't have a genetic mutation identified, then you can screen the relatives with a cholesterol panel. You don't necessarily have to have the genetic mutation identified to screen the relatives, but you do have to screen the relatives with the cholesterol panel. And I'll show you an example of just how effective this can be from the Dutch experience. So in Holland, they have a little bit higher prevalence of FH. FH is even more common than 1 in 500. It happens about 1 in 400 in the Netherlands. And in 1994, they decided that this was a big enough public health burden that they were going to start a national cascade screening program. And this was started in 1994, and they've identified over 9,000 FH patients. And in the first 5 years, they started with 237 FH patients. And when they identified an FH patient, they would send a nurse to all the homes of all their relatives. They would draw their blood, they would test their cholesterol, and they would do a genetic test. And they started with 237 FH patients. They screened 5,400 relatives, and they identified 2,039 carriers. So again, it's autosomal dominant. You'd expect that of the relatives you screen, how many do you think you're supposed to identify? If you screen, about 50% of them are supposed to have FH. Now, you don't have 50%, you have a little less than 50%, probably because some of the people that you were going to screen have passed away early. That's one of the potential problems. The interesting and very important thing about this is that if you look at these 2,000 people that they identified, when they were identified, only 39% were on medications to lower their cholesterol. Now, many of these people would have known that they had high cholesterol, but they did not know necessarily that they had this genetic form of high cholesterol that had led to elevated cholesterol from the time they were born. But 2 years after they were identified by this screening program, 85% were on medications. So it really is very cost effective. This cascade screening is highly cost effective, an approach that uses both lipids and genetics. And it's so cost effective that even the United States Center for Disease Control has classified FH as a Tier 1 condition. And by that, I mean FH is a winnable battle. It's a disease that can be easily identified. There are treatments that cost pennies a day, and if you use those treatments, you can reduce morbidity and mortality basically to that of a normal person without the disease. So they view it as a winnable battle. Of all the genetic testing we do in all of medicine, there are 3 conditions where the evidence is strongest for more widespread use, and those are hereditary forms of breast and ovarian cancer, which many of you will be familiar with, hereditary forms of colon cancer, and FH. And so there are movements afoot in the United States to do more of what other countries have already done. Any questions so far?
Have we ever considered screening newborns?
Yes, that's an excellent question, and we'll talk about that later. And there's many people that think that's a good idea. I mean, we screen newborns now for conditions that are much more rare, and so there's a large movement afoot for that. There's also a movement afoot for potentially screening kids at a little bit later age, because the current pediatric guidelines call for starting therapy for FH around age 8. And so there's some idea that you might not want to screen kids until they're a little bit older, because it wouldn't change really what you did with them. So how do you treat familial hypercholesterolemia? And this is one of the questions that we get a lot. Well, obviously diet and lifestyle changes are really important. You want to reduce the saturated fat. The amount of saturated fat that you eat is directly correlated to your cholesterol level. You want to eat a high soluble fiber diet. Soluble fiber is the stuff that's contained in things like apples. Consider a dietitian referral. You know, it's really hard in the United States to eat a healthy diet, obviously. But you're not going to get there. If you have FH, the most important message that we tell our patients is you cannot get to where you need to be without medications. It's impossible. And statins, which are the most commonly prescribed drugs in the world, are the mainstay of therapy. They do have side effects. Statins do have side effects, but their major side effect for patients with FH is longer life. You do have to treat the other risk factors like high blood pressure and smoking. And the other important thing is that we cannot consider an FH patient like a garden variety high cholesterol patient. These are patients that have been exposed to very high cholesterol levels from birth, and they're therefore, by all guidelines, considered high risk. And by high risk, I mean that we have very aggressive goals about what their LDL cholesterol should be. We can't lower it just a little bit. We need to lower it a lot to compensate for that burden that they've had the rest of their life.
Statins affect those 1,400 SNPs, some of the 1,400 mutations?
They don't directly affect those mutations. What statins basically do is they trick the body into increasing the number of LDL receptors that are on the liver. So in an FH patient, you get a gene for the LDL receptor from your dad and a gene for the LDL receptor from your mom. In FH, one of those that you get is defective. It's not working correctly. And statins trick the body into making that the good copy have more of it. So it upregulates the amount of good LDL receptor that's on the liver. So that's really how they work. They don't directly affect those mutations. So again, the goal, FH patients are always considered high risk. And the rule of thumb is that we need to cut the LDL cholesterol, the starting LDL, by at least 50%. That's kind of the old way of looking at it. But ultimately, in more modern times and more recently, most people are trying to get the LDL below 100 and sometimes even below 70. So again, and in FH patients, usually, even though statins are highly efficacious and highly potent, many times we cannot get to this goal with one medication alone. We often have to use more than one medication. And so we have to have a constant education of our FH patients about this. The most important reason that the most important reason for this is that if we treat FH patients very aggressively, we can reduce their morbidity and mortality, their chances of heart attacks, to similar levels that are seen in the general population. And so this is data from, again, from the Dutch population. This is these are patients. In the blue is patients that have FH that were treated with statins. In the green was general people in Rotterdam that did not have FH. So you can see that if you treat people with statins that have FH, their mortality and this is mortality here, their mortality is similar to the general population. But in FH patients that did not get treated with statins, they're much more likely to die from heart attacks. So it's really important to treat these patients as aggressively as possible. Now, many FH patients, again, cannot get to goal with current therapies. For instance, now I'm going to go back and I'm going to talk a little bit about that more severe form of FH where you inherit a bad copy from your mom and your dad called homozygous FH or HoFH. The vast majority of these patients cannot get to a healthy level of cholesterol with current therapies. And those current therapies include every drug that we have, and as well as this apheresis procedure that they can undergo that scrubs the body of high cholesterol. And a large number of heterozygous FH patients, that's the more common form, do not achieve LDL goals with current regimens. So there have been studies that show that only 20% of these more common form of FH achieve an LDL of less than 130, and only 40% get to an LDL of 130. And we also know that statin intolerance is a big problem. So some people just can't take statins because they get muscle aches or they have other side effects. And in the real world, that's about 10 or 15%. So one of the real goals of cardiology and of vascular biology and of pharmacology and drug companies over the years has been to develop new drugs to treat high cholesterol. And one of the test cases that's used is obviously FH patients. If there's any group out there that needs more medications, it's the FH population. And in the last couple of years, there's been a lot of movement in this area. And, you know, statins came on the market in the early 90s, something around that time. And there hasn't been a huge amount of new medications to treat cholesterol-sense statins, but just in the last couple of years, there's been a huge leap forward, I'd say. And in particular, 2 of these drugs were approved in the last 4 or 5 months to treat homozygous FH. And I'm going to tell you just a few words about them to give you a flavor for what's going on. And both of these drugs act in ways that previous drugs have never acted before. So they're brand new therapies on the market, and they're very exciting, especially for that very high-risk population. So the first of them is called mipomericin, and it acts in a unique way. It actually is a single-stranded DNA, and you inject this single-stranded DNA molecule under your skin, you know, once a month or once every couple weeks. And it actually, that molecule finds its way to your liver, binds to the RNA that is normally used to make the ApoB particle, and degrades it. So these cholesterol particles that are normally made in the liver can no longer be made in the liver, and so the cholesterol doesn't leak out of the liver into the blood, and so your cholesterol levels are lower. Obviously, if you're blocking the cholesterol from getting out of the cholesterol is staying in the liver, the fat is staying in the liver, and so there's some concerns that over time this could lead to a buildup of fat in the liver, which could create a problem. Nevertheless, this drug is very effective. This is the change in LDL cholesterol. So in people that took this drug, their LDL cholesterol went down by about 30% as opposed to people that took control medications. And so this is one of the new medications that was approved, and it's only been approved so far for those patients with very severe, that homozygous form of FH, and it's being used now. You have to get special permission to be able to prescribe this drug in the United States. There are side effects that are associated with this drug. Injection site reactions, influenza-like symptoms are common, and liver function abnormalities are also we have to watch out for. The other drug is called lamidipide, And it's a microsomal transfer protein inhibitor. And this drug was approved, I think, in December 2012 by the FDA, again, for the treatment of homozygous FH patients. And it is an oral pill that you take in various doses, and it goes to the liver and, again, prevents these lipoprotein particles that contain cholesterol from getting out into the blood. And we know that there are genetic forms of people that have no MTP that are born with it, and they have very low cholesterol levels. And again, this drug is very efficacious in these patients that have very severely elevated levels of cholesterol. So this is your change from baseline in your LDL cholesterol. So and this is the dose of the drug that people received. And so with a certain dosing regimen, you can lower your LDL cholesterol by 50%. And again, these are patients that had this very severe form of high cholesterol. So they started out with cholesterol levels 500, 600, 700, and they were able to get their LDL cholesterols down by 50%. Again, we have to be concerned that, or the FDA certainly was concerned that this might not be ready for the garden variety patient because it can lead to fatty liver. And so, again, you have to have special permission to prescribe this drug, and we really use it for homozygous FH only right now. What about kids? This gets back to your question. So in kids less than 10 years old, we have to have a lower cutoff for when we suspect FH, and that cutoff is 130. And oftentimes we can't, if you go to your doctor for a cholesterol panel, they tell you to fast overnight, but in kids that's hard to do. So oftentimes we'll start with a non-fasting lipid panel, and then if it's elevated, we think about getting a fasting one. There are guidelines from the American Academy of Pediatrics, which is a relatively conservative organization. They're not out there advocating for crazy stuff. They now advocate that kids with FH should start therapy to lower their cholesterol by age 8. And statins are, again, used both in children and adults, and there have been a number of studies now for statin use in kids that have shown no increase in adverse events, including sexual development, liver toxicity, and muscle toxicity. Obviously, when you tell a parent that you're going to need to start their child on a medication that they're going to need to continue probably for the rest of their life, there's obviously significant worry that the parents have. And so it's a education that we have to have with them and discuss the risks and the benefits, et cetera. There are some special circumstances that will have to, that can change. For instance, you cannot use statins when you're trying to get pregnant, or if a female is trying to get pregnant, or if they're pregnant, so you have to come off for those kind of circumstances, et cetera. And then here's the great question that you asked. Should there be universal lipid panel screening for adults and or children? And there's a good arguments for why that probably should be done. And the National Lipid Association does endorse universal screening for people starting at age 9 to 11. And many health plans already do lipid screening because they know it's part of good preventive care. So let's go back to our case. So this was our 38-year-old thin woman who had a heart attack, had one young child. And what do we do for her? Well, the first thing is we started her on high-dose statin therapy. That wasn't enough by itself to achieve a healthy cholesterol level. She got started on some other drugs, niacin, to help lower her cholesterol. There's been a lot of talk about niacin lately. It's probably not overused in the general population, but certainly in the FH population, it's a necessary adjunct therapy. Because she had a big heart attack, she was started on medications to prevent heart failure in the future. She was started on blood thinners to keep those stents open that she got, and she was counseled on diet and lifestyle. She was already 115 pounds, but we advocated that she increase her fiber, decrease her saturated fat, and salt intake. She did undergo genetic testing for FH, and we did find the mutation that caused her disease. And so what this will allow us to do is test her child at an early age to find out if they have FH, and potentially even screen other relatives from her family.
Her initial test that you showed, she had high everything except triglycerides were low at 55.
Yeah. So FH is a disease that really affects the total cholesterol, has little effect on triglycerides.
Is it unusual for somebody with high cholesterol to have low triglycerides?
Absolutely, yeah. They're not correlated in a one-to-one type of scenario. So I've told you that FH is vastly underdiagnosed. We know that less than 10% in the U.S. have been diagnosed, probably less than 2%, honestly, if we want to be honest about it. Many of the patients will have been diagnosed with high cholesterol, but very few will have been diagnosed with FH. And so we wanted to see, are we doing just as poorly as everybody at Stanford, and try to change that, because part of the goal is not just to give talks, but it's also to change the management of patients. And so, yeah.
Everybody gets cholesterol testing.
Not everybody.
Well, let's say a lot of people.
The vast majority of people in the United States do not know their cholesterol levels.
Okay.
Yeah, and
all those who get cholesterol testing.
yes.
Is that they would then identify that?
Well, that's the interesting quandary. So let me take you back here to this earlier slide. So you might get your cholesterol testing and say you were found and somebody told you had an LDL of 190. Does that mean that you have FH, or does that mean that you just have a diet that's been high in saturated fat and very sedentary, et cetera? The vast majority of people do not know whether they have FH or not. They might know that they have high cholesterol. And again, the reason that that's important is, your doctor might start you on a statin to control your cholesterol, but what we really need to do is if you have FH, is we need to test everybody else in your family for that.
How would the doctor know that you had FH versus you were in that little?
Right, so then that goes back to what is your family history? If you had a father that died at age 50 from an early heart attack, or if you had these physical exam findings that were consistent with FH, or if you had a sister that had LDL cholesterol that was 250, then that makes it much more likely that you have FH.
And if you know that you have a family history of everyone having, heart attacks
Yeah.
and so forth, does that mean that you're now a person with FH?
That means it's much more likely that you have FH. There are other conditions that can lead to early heart attacks in families. There are other similar conditions, but that are not as common or as FH.
And do the primary care doctors know what to do?
No, they don't. That's the problem. That's why I'm giving these talks. That's why we're trying to educate the public, because I'll tell you, I gave a talk to the genetic group at Stanford. These are people that are being trained in genetics. They know every syndrome known to man. If they see a facial abnormality or something like that, they can tell you exactly what that is, how often it occurs, et cetera. And I gave a talk to FH to them, and it was not even on their radar. And so this is an extremely common genetic condition that we have easily cheap therapies for that is not being publicized nearly as much as it should be. And so we're trying to get the word out.
Therapies, or did I blank out?
Yeah, so the therapies are statin drugs and other drugs and diet and exercise, et cetera.
So the primary care doctors are good at that.
They are good on that.
They'll put you on the statins and they'll give you the exercises and the diet.
Right.
But they may not identify you as
FH, exactly.
So does that matter?
Right, so why does it matter? Again, it matters because you have to look at the rest of the family. You have to be more aggressive. If I determine that you have FH, your cholesterol goal is no longer 130, your cholesterol goal is 100. Your kids need to be screened at an early age. Your brothers and sisters need to be screened, et cetera, et cetera. Let me just finish the last slide, and then I'll have plenty of time for questions. So I told you that FH is it's very common, and it's very underdiagnosed. And the most important way of looking and trying to diagnose it is the cholesterol level. If the cholesterol level is normal, you don't have FH. And so we went back and we said, and we care for about 50 patients with FH at Stanford. And we went back and we looked at Stanford's medical records just to simply ask, how many patients at Stanford that have ever had a clinical lab at Stanford have an LDL greater than 190? And if you look at this calculation, there's 870 patients that have had a cholesterol value at Stanford over 190, an LDL value. Now, not all of these patients will have FH. Only about 20% of them will have FH. But it's still, that's a sizable number. This is the kind of screening study that can be done in the electronic medical record system at the VA, at Kaiser, whenever you go get your lab drawn at Quest or at LabCorp, they could flag an LDL cholesterol value because we need to start diagnosing these people. Now, the mission of the FH Foundation, which was founded by a woman in her mid-30s, very similar to the one I presented, had been dismissed by multiple doctors, including cardiologists, had been told that she had high cholesterol, but there was nothing to worry about, had young children, had a heart attack at an early age, and finally figured out that she had FH and had been misdiagnosed. And so she founded an organization to increase the diagnosis, awareness, and treatment of patients with FH, and has just made remarkable progress in the last year and a half. And one of our goals is that we're going to be starting a national patient registry for patients with FH, and the goal of this is to try to turn the tables. Instead of less than 10% of patients being diagnosed, have more than 90% diagnosed. And the only way you can do that is to start with single patients. You identify that single patient, you look at the rest of their family, you find those family members, you get them in the registry, and you change the way that we treat FH. You bring those patients together, they start having dialogues, they start having a community where they can talk to one another. I think it's critically important. And I'm going to pass out some literature at the end if any of you guys are interested. So here's the post-test quiz. So what is the prevalence of FH in the general population? How common is it? 1 in? Okay. Patients are at what fold increased risk of a heart attack? 20, right? What is cascade screening? Screening of family members, right? What is the goal LDL for a FH patient? 100, good. And mutations in 3 genes cause FH. Give me one of them. The mutations in the 3 genes. So the LDL, what binds the LDL in the liver? The LDL receptor. The LDL receptor, that's the most important one. That's a hard one. All right, now that's it. I'm happy to answer any of your questions.
So the best screening cholesterol is a total?
It's your LDL. LDL.
Just a fasting LDL.
Fasting LDL or direct LDL. We can now measure LDL, any kind of LDL. Total, you can use total to diagnose it, but most of the standards are based on LDL. There's a different cutoff. If you want to look at total, there's a different cutoff that you would use. But what we're trying to get out, it's confusing to the public. You have total, you have LDL, blah, blah, blah. We're trying to get a consistent message that, what you should do is be looking at the LDL and diagnosing it. Get one number in their head. And what is that one number? If you're going to remember one number for LDL, what number would that be? 190. If your LDL is above 190 and you're not on therapy, then you should be concerned for FH.
What is the ratio if you're on a statin drug?
You have to correct by about 30 or 35%.
It's the same condition happen in the brain during stroke that happens in the heart for heart attack. In other words, the same kind of cholesterol.
Yeah. So there's many kinds of stroke. There's hemorrhagic stroke, which is caused wherein blood vessels sort of bursts and leaks blood into the. And then there's also called embolic strokes. And embolic strokes mean a cholesterol or a bit of plaque can rupture from your carotid arteries or from your aorta or something and go up into your head. And the same kind of risk factors that you have for heart attack are the same kind of risk factors you have for stroke. Some things seem to put you at higher risk for stroke than heart attack, like hypertension, high blood pressure is a stronger risk factor for stroke than it is for heart attack, but high cholesterol, high blood pressure, diabetes, all these things are risk factors for both.
And if your heart and brain tend to clog up similarly in the same person, do you have a clear brain and a clogged up heart?
Yeah, obviously the number of heart attacks in the country are much more common than happen much more often than the number of strokes. So you can have one without the other, but commonly they go together.
Is it a given that your children will have this condition if you have it?
Right. So it's 1 in 2 chance. So
is it possible so that if these people eat a good diet,
yep,
do a lot of exercise and perfect health,
yep,
they'll still have that gene?
Yes. Yes. So the gene is passed. It doesn't have anything to do with your environment. If you have FH, say you had 4 children, each of those children would have a 1 in 2 chance. So you could be lucky and have none of those children inherit that bad gene from you. Or you could be unlucky and have all 4 of them inherit that bad gene from you. But on average, 1 in 2, 1 out of every 2 children. It's a roll of the dice, 50%. Each child has a 50% chance of having it.
So there is a possibility that they have a 50% chance.
They have a 50% chance of inheriting that bad gene from you.
Now, I never had this cascade screening.
Yeah.
I only assumed that I have this condition because I was told I had high cholesterol.
Yeah.
I took medication. I don't like to take medication.
Yeah.
I don't like what I read about it. So we did a test and I stopped.
Right.
Now, I eat a very good diet, thin, the exercise, but my cholesterol kept going up and up and up.
Yeah.
So I assume that's what I have.
Well, you'd have to have a meeting with your doctor, somebody like me or somebody else that would know what to look for. They'd have to ask you what was your family history. They'd have to look for the telltale physical.
My mother had 300 cholesterol, never took anything, and she lived to over 100. Never had a heart.
And that does happen.
Never had a heart condition.
That does happen, but then we'd also have to look at the telltale signs of FH, the physical exam findings. We'd have to look at other family members, not just your mother, your kids, what their cholesterol is. No way of knowing whether you actually have FH. But if you did have it, you would not be able to lower your cholesterol just with diet.
One of my sons does.
Right.
Take a
Statin drug, yeah.
Could you tell us the side effects of the statins?
Yeah, so the side effects of statins are myriad. The most common thing that people complain about is muscle aches and pain. That happens about 10% of the time, 15% of the time. And then people complain about all kinds of other things. Some people say it diminishes their short-term memory. In the large trials, we've never really found a signal for that. Some people say it causes abdominal discomfort. Never really seen a signal. The major one is really muscle aches and pains.
How about calcium, bones,
Yeah.
osteoporosis?
No, it doesn't. There's not a signal for that. No. Yeah.
That's all. That's the only.
Those are the major side effects. The major side effect is muscle aches and pains, honestly.
So you mentioned this longitudinal study, I think it was in Norway?
In the Netherlands and Holland.
Netherlands,
Yeah.
so long-term. And
Yeah.
you made some other reference to, I think it was the first other drug therapy that you covered, it began with an M, that was out of the U.S. Is there an impetus for the drug discoveries outside the U.S.? And
Oh,
if so, why would
absolutely.
that be?
Yeah, because the same things happen in the U.S. as happen in other places, and that is, we have great drugs, but even though we have great drugs, many people don't get to where they need to be with what's available now, and so that's really the impetus for these new drugs coming out. And so the clinical trials to test these drugs are being done all over the world. Some of the trials are being done in South Africa. Some of them are being done in Europe, in Australia, in the United States, in Brazil. They're all over the place.
Anything in Asia? Or no?
Asia as well, yeah, certainly in Japan.
What are the differences in the statins? They're different. Like
They're different names. There's about 10 different ones, and they all work in the same way, but they're all metabolized in slightly different ways. Different enzymes in the liver help break them down or help clear them, and they're slightly different in their potency levels. So some of them lower LDL by a little bit more than others of them. Some of them last a little bit longer in your system than others. Some of them have a slightly higher side effect profile than others.
how does the doctor decide which one is to give?
Yeah, so that's a good question. So at first there was only one to choose from, and then there was 2 to choose from, and then there was 3 to choose from. I'll tell you that the 2 most commonly prescribed drugs in the world now are both statins. One is called simvastatin or Zocor, and one's called atorvastatin or Lipitor. And why are they the most commonly prescribed drugs? Because they have a combination of 2 important features. One is that they're very potent. They lower LDL cholesterol by a lot. The second is they're generic. And so those 2 medications have that favorable combination. They're potent and they're generic. So doctors feel good, and they've been around a long time and we know they work. And so those are the 2 most commonly used ones. Then there's a few others that have a little bit less side effects, like pravastatin or fluvastatin, that have a little bit low side effects but are a little less potent, and so they're not as commonly used. And then there's ones like rosuvastatin, which is also very potent but not yet generic. And so it's just It's individualized, but most people will start with one of the potent ones that's generic.
If you had a homozygous patient or came across one at Stanford
Yeah.
and determined they needed apheresis, how would that patient get treated?
Yeah, so there are, so apheresis, so the homozygous FH, again, is 1 in a million, so there's probably 200 patients in the whole country that have homozygous FH. And so, and there's less than 50 apheresis units in the whole country that perform this apheresis. And apheresis is a dialysis-like procedure to scrub cholesterol. So a patient that needs apheresis goes into a center, they have IVs put in their arms, their plasma is filtered out of their body, it goes through a filter which removes the cholesterol, and then the plasma is put back into their body. And you have to do that once every week or two in these very severely affected patients. And it's obviously very annoying for the patients to have to do it every couple weeks, and it's very costly, et cetera. I mean, it's estimated that it probably costs $250,000 to do that a year for those patients. And so, and for hospitals, it's also very expensive, because for a hospital to break even on an apheresis unit, you have to really treat 2 to 4 patients a year, or else the hospital loses money. And at Stanford, we don't have 2 to 4 homozygous patients, but there is an apheresis unit in Millbrae, I think, in South San Francisco, that's run, and we've referred patients up there for apheresis, and some of them go and some of them don't go.
So the apheresis units for this procedure for scrubbing the cholesterol are not the same as the ones in the Stanford Blood Center?
No, they're different. It's a different, it's analogous. It's done in the same sort of way, but it's just a different filter. Yeah. It's not that it would be impossible to do at Stanford. It's, you know, like many things, it's a cost-benefit analysis for the hospital.
Those 3 gene mutations you showed, are they translatable into the RS designation? They are, you know what I mean, the RS for the number?
Those are the three genes. There's 3 genes. And then, for instance, in the LDL receptor, there's over 1,600 mutations. Many of those would have an RS number. Yeah.
Oh, so it would go into many RS designations.
Yeah. Yeah. Each mutation would have an RS number.
Yeah, several years ago, I think 60 Minutes, there was some program or some feature about some Italian town that everybody had a cholesterol level of over 400.
Yeah.
How is that related?
That's a different phenomenon. That's ApoA Milano. That's a mutation that leads to very, very high HDL cholesterol, and those people seem to be protected. And there's drug trials going on to try to use that therapy as sort of a Drano for the arteries, but those studies have not been universally positive.
I was curious about some of the photographs that you showed. You showed a set of 4 photographs
Yeah.
where you said, you know, people, you can actually look at them and tell that one.
Yeah.
So you can actually look at people and say, okay, they have
FH.
they
Yeah.
have FH.
Yeah, if you have swelling in the tendons of your Achilles or your elbows, there's almost nothing that causes that besides FH. If you have swelling down here and you have very elevated cholesterol, you have FH. There's nothing else that causes that combination. It's cholesterol deposits there.
Just not in the blood vessels.
It's been so much that's in the blood vessels that it just leaks out sort of and sort of deposits there. So we have patients that will come and they'll say, you know, I had this stuff under my eyes and I didn't like the way it looked. And so I had my dermatologist, you know, take that out. And what did they find? They found cholesterol. And then the dermatologist said, this is not normal to have cholesterol there. You know, you need to go see somebody. Or patients that have had, you know, lumps and bumps on their elbows, and they say, oh, I don't know what that is. They go get it biopsied, it's cholesterol.
So it's not necessarily just because they're overweight that they
No. FH is genetic. It is very slightly related to your weight. I mean, that's not the major effect.
well, you know, you really should lose weight. You're highly overweight. Maybe they'll go away.
No.
What's different in the heel there?
This is you can't really see it that well here, but it should be about this thickness, and it's kind of just thicker here. It's just swollen. You can't really. It's just thicker. Many times these patients will have ruptured their Achilles, or they'll have Achilles tendonitis or something like that if you go back and really search.
Not only eye thing, you see that in a lot of older people.
Yeah, these are not, none of these things, this thing you can see in older people, but if you see it at a very young age, then it's much more likely to be FH, you know, than old age.
In older people, it could just be age.
Yes, absolutely. Yeah.
But you never mentioned HDL.
Yeah.
So how does that?
Purposefully. I don't want to confuse HDL is a very, very confusing topic and very changeable. The message to the public has been quite confusing over the years. HDL, higher HDL is the good cholesterol, is clearly associated with better outcomes. If your HDL is high, you're less likely to have heart attacks. No relationship to FH, you know.
Because sometimes you say, oh, my HDL is so high,
Right.
it doesn't matter.
In FH, that's not, it might be a little bit protective, but not greatly.
So the higher the HDL, the better.
In general, if you look at huge populations of people, the people that have high HDL tend to do better than the people with low HDL.
But the key is keep it under 100.
The LDL, yeah.
Okay.
Yeah. I like to say it's the LDL stupid. It's the it's the economy stupid. It's the LDL stupid. It's the economy stupid. It's whatever. It's the LDL stupid.
Well, when you say 30 to 35% the statin drug, so do you take, is it 30% of the lower number or 30?
Statins drugs tend to lower your LDL cholesterol by about 30%. So if you
If the higher number, that's 30%.
yes, yeah.
The HDL study that you mentioned in the Italian
Yeah.
town, isn't that the work that was recently published by Fahim Abbasi of Gerald Raymond's group at Stanford? They just
Well, I work with Fahim every day. And I don't know that particular study.
A longitudinal study for about 12 years with Washington and a hospital in New York that I can't remember the name of at the moment.
Not on ApoA Milano. They've done another study. The study that you're talking about has to do with insulin resistance, not ApoA Milano. They're two different things in Italy.
Okay.
Two totally different, separate things.
Did you say the word again?
Insulin resistance.
No, not that one.
ApoA Milano.
Yeah, how do you spell it?
M-I-L-A-N-O. M-I-L-A-N-O.
Milano, what was the first one? Apollo?
Apo, A-P-O-A, apolipoprotein A, Milano, yeah. Well, that's a lot of questions.
So if you were going to have your cholesterol tested,
Yeah.
you go to your primary doctor and
Yeah.
they go, oh, this is here and this is here, what would you ask them to see if you do have it? I mean, what?
Well, the
because
key number is,
sometimes
the key number is your LDL. What is your LDL?
So if it is 190,
Yep.
then you say, I'd like to be tested.
Then you say, I'm concerned that I might have FH. Either you need to look for the physical exam findings for FH and talk to me about my family history, or you need to send me to somebody that knows what FH is so they can think about it.
So does high cholesterol run in families?
Absolutely.
Even though it's not necessarily genetic, it just runs in families.
Yeah, because remember that families, you don't just inherit your genetics from your family. You inherit what you like to eat. You inherit how much you exercise. You inherit how much you smoke, how much TV you watch. So there's a lot of things that run in families that are not genetic.
So do you think it's in some cases where it runs in families, it's environmental?
Not at that extreme cholesterol levels. I mean, those cholesterol levels are double what a normal cholesterol level is. So yes, you can have elevated cholesterol levels, but FH is a different beast. The cholesterol is just much, much higher than you would be able to normally attribute it to the environment.
So, looking at the treatment, so if you take your statins and you keep it under 100,
Yeah,
so is that the solution? What is that?
that is the
anti-sulfate?
solution. That's what the Rotterdam data, that's what the Dutch data is showing. If you could treat your LDL and get it to a very healthy level, you can be thought of as being just like anybody else.
That means that there are no more deposits in your arteries.
It means there's no Drano for the arteries. Okay, once the deposits are there, they're there. The treatment that we're giving people is basically to prevent those. No, we can't. It doesn't take it away. It might reduce it extremely, a very, very, very small amount. And I don't want to be, too dogmatic about this, but basically, once the lesions are there, they don't go away. What we're trying to do is prevent them from getting bigger and prevent more of them from occurring. Now, if you treat somebody's cholesterol extremely aggressively and get their LDL down to less than 70, and you follow them for a really long time, that lesion that you have might shrink by 1 or 2%. There's not like magic to make it. There's just no Drano yet. That's the magic. That's what everybody's looking for, but we haven't found it.
So if I have children
Yep.
who are grown,
Yep.
and they may have this gene, but right now it's not showing up at all when they have cholesterol.
They would not. If they have the gene, it would show up. That's what I'm telling you. If they have the gene, their cholesterol is going to be elevated. That's what this condition leads to. If you have a gene that you've inherited from your mom or your dad, it will lead to high cholesterol.
So, but if they see, maybe close, will it go up as they age? Or
Everybody's cholesterol goes up as they age, but at any time point, ever since they were born, their cholesterol will be elevated.
So you suggest this screening because the earlier they start a statin, the less lesions there.
Absolutely. Yes.
So it's not a good idea to take I know a kid who has high cholesterol and they take these naturopathic
Yeah.
things
Yeah.
rather than the statins.
Yeah.
Is the niacin enough for that?
Well, every case has got to be thought of on an individual basis. I can't give individual medical advice, but in general, the way I feel is that a lot of the drugs that we have came out of natural remedies. But if a natural remedy is going to work, it should be tested in the same way that every other drug is tested. The natural homeopathic remedies to lower cholesterol are things like red rice yeast. Red rice yeast contains basically a statin. So if you're going to take red rice yeast, why not take a statin that has much more quality control, that has much more efficacy data, that has much more, much less chance of having a toxic metabolite in it, that's been rigorously tested. Homeopathic remedies, some of them are going to work, and we should study them. But for a condition like FH, which is deadly serious, you should be deadly serious about it.
One last question from me. Sorry. When you take statin drugs, it's having a certain way of effect on the blood. And then people also take blood thinners because it's heart attacks and so forth. So do those two things work well together? Do they sort of complement each other? Or?
In certain conditions, they complement each other, but really the statin drug is meant to lower the cholesterol, and the other drugs are meant to, quote, quote, thin the blood. And patients that have a high risk of cardiovascular disease, you use the combination of those things to prevent more heart attacks. So yes, they do act together in a helpful way in many cases.
And Doctor, that would be a great last question if that's okay.
Yeah, absolutely.
Thank you